So we have plenty of time to get to the presentations. I'll go ahead and start right away. Obviously, today's presentation is on collaborating with medical institutions, and I think this is a really good first topic for this Brownbag series, because I think it's really fitting. As social and personality psychologists, we probably have a lot of training in research methods, experimental designs, maybe even working with convenient samples of young adults or undergraduate populations. But if you're interested in health research and going into more health research, you may be interested in taking work out into the, drum roll, please, the real world. And so if you're studying health issues in the real world, one way you can really beef up the applied nature of your work is to work with either medical patients as participants or doctors and physicians as possible participants. And so this is true whether you're looking at topics such as how people cope with illness, treatment decision-making, adherence, patient-provider communication, behavior. I mean, there's tons of topics where medical populations would be relevant. And so there's a wealth of opportunity to apply social and personality psychology to the health domain by collaborating with medical institutions. So we're fortunate to have with us today 3 people who have experience working with medical institutions to tell you their advice about what to do to make things go well, or perhaps what not to do based on their experience. They include Irene Blair, who is a professor of psychology at the University of Colorado. We have Kate Sweeny, who's an assistant professor of psychology at the University of California, Riverside. And myself, John Updegraff, who is associate professor of psychology at Kent State University. And so we've tried to anticipate the kinds of questions that people would like to have answered as they think about how to go about collaborating with medical institutions. So each of us has a short presentation that we're prepared, that we have prepared to describe the kinds of collaborations we've done, as well as our advice that we can provide on how to make such collaborations go smoothly. So each of us have a PowerPoint presentation. You should be able to see the PowerPoint slides on the screen. I've talked with each of the presenters, and each of them are happy to answer questions as they come up during the presentations. We should have enough time for general questions and discussions at the end of the 3 presentations, so towards the end of the hour. So if you have any questions during presentation, feel free to unmute yourself and ask a question. If it does look like we're getting pressed for times, I may ask to save some of the questions until the end. So if that structure works, we'll go ahead and get started. I know Irene Blair has graciously offered to go first in terms of presenting her side of the story. So I'm going to switch the screen over to Irene. And Irene, are you?
I think I'm on. I said
Okay.
show my screen. Are people seeing my screen?
Yeah, I see your screen.
Okay. All right. Let me make this so that you don't see all these odd things. And I think, not sure how to make that go away. Maybe it doesn't. Okay. Here we are. Need to go back, start out. So, well, thank you for the promotion. I'm actually an associate professor in psychology as well at the University of Colorado, Boulder. And I thought I would start by just noting that a typical social psychology research collaboration, to the degree you even have colleagues around to collaborate with, or at least this is my experience, is, it's typically me, another faculty or two, a graduate student who's the one who's brought us together, and maybe a couple undergraduate RAs. And that's about it, that we pretty much run the whole show with this group. In working toward doing research in a healthcare setting, I actually exploded my group up to this level, which was very novel for me, working with individuals at Denver Health, which is a safety net, primarily minority-serving institution here in Denver, Kaiser Permanente, Colorado, Snowcap, which is a network of private practices who agree to be involved in research if you can convince them, more or less. And then another big change for me was having the statistics move out of my hands and into the hands of biostatisticians. So they are at the School of Medicine on the Denver campus, and I'm here in Boulder. So this is what my research program has morphed into. To give you just a little more background, this is the timeline of my work in this area. So 2005, actually, I was on sabbatical and decided that I wanted to do some healthcare related research and started calling around to folks knowing that I would need collaborators. So I started having our first discussions, talking about what kind of project we might do, figuring out what personnel, what other people we needed to pull in for this project. It became apparent very quickly that we could not do the project we wanted to do on a small scale, that it was going to have to be a large-scale project, and that's because we wanted to study healthcare providers' implicit and explicit ethnic racial biases and the degree to which that relates to patient care. And you can imagine that would be very sensitive for one organization to step out to do that, particularly back in 2005. There have now been a few publications on this topic, so I think it's becoming a little more normalized, but at the time, you know, we would talk with one group and the CEO would say, well, we think this is important, we want to participate, but there's no way we're going to do this on our own. So we realized very quickly we were going to have this big group to do this kind of project. So you can see it took us a while, about 3 years, to actually get our grant funded. So one of the things that I think probably a few people will mention is that work, at least the kind of work that we wanted to do, there was no way to do it without grant funding, so that had to be the first step, and that took about 3 years, including some pilot data collection. We then had to get IRB approval. Now, instead of just my group here in Boulder, we had to go through 3 different IRB boards, 2 rounds in each. That took about 6 months. And then we started data collection, and that's been going on. Actually, we have finished the primary data collection, and we're now looking into patient medical records, so that's its own kind of data collection and analysis. But you'll see that from 2005 first discussions to 2011 was our first publication, and it was a conceptual piece. We now have a couple papers that are empirical under review, but you can see the kind of time we're talking about here, that this is really a long-term commitment to do this kind of work. So John had sent Kate and I some questions to get us started on why one would want to collaborate, how this would all go. So I've just kind of listed out here those questions and my answers to these, though I hope we will get a chance to have some discussion about this. So my reasons for collaborating with a medical institution, or in this case several medical institutions, was because I wanted to study medical processes. I wanted to study the stereotyping prejudice processes that I was used to studying in the lab in a different context, to see how far our theories and our methods could stretch, and to do that I had to go outside of the lab. This gives me the opportunity to work with, quote, real people and problems, and not that undergraduates and their problems aren't real, but this is really quite different to be talking with patients and physicians in these places, and to think outside the box. This collaboration really pushed me both theoretically and methodologically and statistically to go to places I would have never thought to go with my work. How to locate a good potential collaborator. At least the way I went about doing it was to find people who were already doing some kind of research, and to try to find researchers who might be interested in some of the same issues. So although I didn't find anyone in the medical community actually who had even really thought about providers' biases and stereotyping and prejudice, there were researchers very interested in minority health. And so those are the people I went to. Looking in primary care, I think, is a good idea, because primary care physicians and researchers tend to be a little more interested in the processes that social psychologists are typically interested in. To pitch an idea, I walked in with the IAT, and I'm sure many of you, if not all of you, are familiar with that. And that's just a fun tool in the sense that people do it, they feel compelled by it. So that was my hook, was to go around doing kind of IAT demonstrations in meetings with lots and lots and lots of meetings, but with everyone from administrators down to researchers. I had to become familiar with their issues, what they're interested in, And again, for my research, that was the huge problem of ethnic racial health disparities. That's a really well-documented problem, and it's a problem that has enormous support through the medical community and political, also political force to solve this problem. So that was the issue that we had in common. We also linked this to hypertension control, which is a big problem, and then, of course, the money, getting the grant money. So that was how we would contribute to their goals. In my experience, the signs of a good medical collaborator, first of all, I think FaceTime is really important. Someone who has time to talk with you and wants to talk with you. You're not the last item on their list, and they'll get around to it if they can. I think that's actually really important. Finding people who have research experience is very helpful, and seniority in the institution. That's not necessary, but I think it is helpful. I think if you don't see mutual respect and admiration, that is definitely a red flag there. So, you know, I walked into this group and started talking with people, and it was very clear they respected the social psychology perspective. And I also made clear that I appreciated their medical perspective. So that was good. And then it was really just lots and lots of fun as we talked about what we wanted to do. So I think fun is an important indicator here as well. Important tips for navigating medical IRB issues. This was something I had never done before, and I thought it was extraordinarily helpful to have people on the research team who had worked with those specific boards. And it wasn't just IRB boards in Boulder who are used to psychology versus medical boards, but even the medical boards were really quite different in their concerns and their forms and what they wanted to know. So having expertise in our group at each of those specific boards was very helpful. So for example, Kaiser Permanente board, you are expected to show up when they are going to discuss your application. You're expected to be at the meeting, whereas the other board for the other medical institutions in Denver, COMERB, you can't get into the meeting if you know, however hard you try to get in there and explain your method. So these are very different approaches. You want to know their concerns underlying their questions and address those concerns. So, for example, at Kaiser, I found out that in their asking about the collaboration, what they really wanted to get at was, is this a real collaboration? And I guess there is an issue with Kaiser Permanente because they are so large and have such great resources that a lot of researchers want their patient population, want to get into their databases, but they want to do their own thing and not include Kaiser as an equal partner in that work. So that was a very serious concern at Kaiser, and so we had to make sure we addressed that in a way that would allay that concern. The other thing that I found that was pretty different, and you know, this is in part a medical issue, I think it's also, I think IRB boards are moving in this direction generally, but it is really difficult to change documents, questionnaires, question format. If you're going to go from a 4-point scale to a 7-point scale, my colleagues consider that a significant change, and that we need to go through a revision application at the IRB. So, you know, right, we're talking about all these different IRB boards, and we're supposed to, you know, get every tiny little change approved. So, you know, so some of that, of course, is just going to happen, but to the degree that you can anticipate this is the way they might view it, then I think you can save yourself some headache. How to keep a collaborative study running smoothly. I think it's really important, and this is of course true for any collaboration, to have a very clear delineation of duties, and that was certainly difficult for me in the beginning, in part because I just didn't know what everyone did and what everyone was expected to do because I'd never worked in that kind of a group before, but I think it is important to do as much as you can. I think it's important with a collaboration, particularly with medical folks, to get a meeting on the books and a standing meeting if you can, because their schedules are going to fill out months ahead in advance. They can't just look a week out and find a time that you really want to say, okay, on the third Wednesday every month, we're definitely going to meet at 3 o'clock, and that makes it actually a lot easier. You're going to spend a lot of time with staff, and that means you have to know the practical issues, and I think Kate and John will talk about that some more as well. You're going to need to keep everyone in the loop, but don't waste people's time. So that was definitely a balance for me, not to have a meeting and then go through all the minutia, because the MDs in the room just stare off into space and they're annoyed because you're wasting their time, but at the same time you don't want to just never communicate with them. So there's definitely a middle ground there. Assume that you'll do most of the work. Okay, how are medical collaborators different from psychology collaborators? It's definitely a different language. I think it's not unlike going into a foreign country where you don't speak the language, and you know, you just have to assume communication is going to take time and to try to be respectful and patient. My experience in this collaboration is that if there's no money, there's no research. There's no, you know, running 50 copies of your questionnaire off and asking them to pass it around if you can't pay for staff time and investigator time. There's also a different role for theory, although they were very interested in theory and thought that was important. It was secondary. So whenever there are design methods or analysis issues, I often feel like I have to be the one to really keep reinforcing what we have to do for the theoretical reasons as well as practical reasons. I found there was little room for adjustment and exploration after studies begun. So again, this kind of thing of, well, you said you were going to do these 3 analyses of the data. Now you want to do a 4th analysis, you know, like that's problematic. Anticipate that the medical collaborators typically assume that staff will do the work. They aren't going to be down in the nuts and bolts of things, I think, to the degree that social psychologists are used to doing. Patient welfare is number 1. And although I think we, you know, obviously go through ethical standards and treating subjects and so on, we don't have the same level of concern with patient welfare or with our subject welfare as they do in a medical institution. And then I just put a couple notes here about how data analysis, writing, and publication occur very differently. But I think I will stop here and save that for discussion.
Okay. All right. Thank you, Irene. We can, Irene, do you want to take a couple questions now?
Sure, I'm happy to.
Okay. If anybody has any questions, remember, please unmute yourself if you want to speak. There should be a little green microphone button towards the top of the screen. If you have questions, you can also, there should be a question box on the control panel towards the bottom where you can type in questions. So if for some reason you're having trouble with audio, you can also type in questions as well. We'll give a couple moments here if anybody has any questions that they want to ask of Irene before we move on to Kate's short presentation.
This is Kate, but Irene, can I ask you a question?
Yeah.
Yeah.
And you may have said this and I just missed it, but I was wondering about your timeline. How did you collect pilot data without the further steps down the line? So you said you had pilot data, and then you applied for the grant, and then you got IRB, you know, all of that.
Yeah.
How did you do sort of the first piece without the latter pieces?
Right. So we didn't get pilot data on the primary question. So our primary question about how physician bias relates to patient care, we thought we would just go into one clinic and study the physicians and patients in one clinic, and that's when we got shut down by the CEO of the healthcare organization. So we knew we couldn't collect that kind of data. Instead, what we did is we collected IAT data in a community sample. Excuse me, because part of our research was to do that, so to show that feasibility, that we could administer the IAT downtown Denver to a community sample of folks who would not have a lot of computer literacy, that we translated to Spanish and so on. So that was the kind of pilot data we got, and yes, we had to go through IRB approval for that, but that was very easy.
Right.
To go. And then we also did a pilot study with physicians completing online IATs, again, just a feasibility study.
Mm-hmm.
And a similar kind of thing that was relatively easy to do.
Great, that makes sense. Thanks.
Okay, does anybody else have any questions? If you do have a question, if you can't for some reason access the unmute, you can just shoot a question in the little chat box and I can unmute you. Okay. If there are no questions, then we'll go to Kate. Actually, first I just want to, let me switch over the screen, change back to me as a presenter. And so just to clarify to everybody there, in terms of how to unmute yourself in case you came in late, when you see the control panel, there should be a little button here. Whoa, a button right here that if you, right now I think it should have a little red line through it. If you click on it, then that should unmute yourself for questions, and then you can click yourself back to mute yourself. So let's go on to Kate's presentation. Let me bring it up. And here it is. It's all you, Kate.
Hi, everyone. Actually, Don, you can flip to the next one. This isn't very informative.
Okay.
Just a bit maybe of background. So as John said, I'm an assistant professor at UC Riverside, and I'm in my, I guess, midway through my 4th year in this job, which may be more relevant to this presentation means I'm also midway through my 4th year out of grad school. So I came straight here. And in regards to medical collaborations, had essentially no, maybe essentially is even an overstatement, I had no experience collaborating with medical institutions of any sort, really doing anything except, I guess, a handful of online studies and then a bunch of, cute experimental stuff in the lab. And so when I got to this job, I knew that was an interest of mine, but had no idea where to begin. And I think I maybe came in a bit idealistic, as probably most of us do, and then rapidly figured out within the first year or so that, it may not be feasible for me to really go out and find productive collaboration before tenure. I'd keep my ears to the ground, but otherwise I wasn't really sure that it was going to happen. So it was to my surprise when about, I guess, maybe towards the end of my 2nd year here, Robin DiMatteo, who's a colleague of mine, has the office right next door and who has decades of experience in patient-physician communication research, adherence research, and has done many productive collaborations with medical institutions. She was contacted by, as you can see on the screen, the Riverside County Regional Medical Center, which is about 10 miles down the road from us, if you're familiar with the geography. It's in Moreno Valley, California. And their Department of Surgery contacted her without getting into a lot of details of the story. Basically, UC Riverside is hopefully very soon going to have a medical school, but a medical school that does not have an on-site hospital. They'll be collaborating with community hospitals for residency programs and so forth. And so this RCRMC Department of Surgery had just been approved to have the first residency program to eventually be affiliated with our medical school, which we hope will open next year. And so they had contacted Dr. DiMatteo to see if she could get some research up and running in their department, because I gather that part of a residency program needs to involve research. And so they needed her or someone to get some research off the ground. She very generously pulled me in as someone who she knew needed these sorts of connections. And so it kind of fell into my lap in what at the time certainly, and to some extent still, seemed like a really fortuitous way. What I will warn you about, and the reason actually that I was very excited that Irene was going first, is that my experience has not been all success from that point. So I think now that I've actually heard Irene's presentation, I've gained some insight into the fact that if you were setting out to find a good medical collaborator, this would not have been the collaboration to have. And so there really almost nothing that she said was true of this place. They had virtually no experience with research. Certainly, I think maybe literally none with kind of behavioral, social science kind of research. They had no experience collaborating with academic institutions. They had basically no researchers on site. And so they were very excited to have us, a bit out of desperation, but had almost no idea how, maybe really no idea, how to go about this collaboration. As you've just heard me say, neither did I, so that was maybe it was doomed from the start. But having said that, as you can now also see on the screen, not doomed entirely. We did manage to get through. So I'll kind of walk through the timeline here and then try to give some I guess, pointers, and maybe they may end up feeling a bit more like warnings from my experience in the trenches. We're still very much in the early stages of data collection, so I don't have the viewpoint of a completed project with publications coming out of it yet, but hopefully that's in our future. So again, basically the timeline was that around April 2010, we had this initial contact. Robin pulled me in at that point. Fairly quickly, it seemed like things were moving very quickly at first because the main contact we had, who's the lead surgeon, and I think actually he's an important administrator at the hospital. I can't quite remember his title, chief of something. But he was really a great collaborator and very enthusiastic, no clue about research, but a lot of enthusiasm for what we were talking about. And so fairly rapidly, I, with Robin's help, put together kind of an idea of how we might work within the Department of Surgery and their various constraints at that hospital. By the way, noting I have no particular interest in surgery or surgical care, but that was the opportunity afforded to me. So I kind of put together a very broad idea of what we might be able to look at that would kind of meet some of my interests in things like expectations and health communication, while also giving back a little bit to the hospital and to the people there in terms of providing some feedback about the quality of their care, which is what they were really interested in. So after putting this together, this was actually one of the funnier moments throughout this process. Robin and I went to the hospital for what we thought was going to be a small roundtable meeting with 2 or 3 of our contacts there, and we walked in the room, and it turned out to be grand rounds with about 30 or 40 physicians in the room and medical students, and so I gave what turned out to be a rather formal presentation to this group, and that turned out to be great. They gave some good feedback about feasibility, had some good questions, and this was really my, dunking all the way in first experience of some of these communication issues that Irene talked about. I found Robin graciously would sort of help me to communicate properly things like that consent procedures would be very important. If you're speaking to other researchers, that seems like sort of a foregone conclusion. Of course, consent will be gained. But, I was talking about these procedures without mentioning consent, and some of these surgeons were looking panicked, like I was going to somehow, coerce their patients into cooperating. Obviously, that was not the plan, but, so I started to realize rather rapidly that I was maybe in over my head, but I pressed on. And so from that meeting on, we were fairly encouraged by that meeting. And so, and what you can see was a fairly long process, about 6 months. I worked on developing the materials for the study, and of course that was not all just coming up with questions. That actually happened pretty quickly. I'm used to doing that, but this also involved long delays at times. I'll talk more about that in a minute. In terms of getting in touch with the staff people at the hospital who I needed to talk to figure out things like how in the world would we get our research assistants kind of oriented, what would be the requirements in that regard, how I'm sort of looking for it. I've been very lucky, I guess, to not actually ever had surgery. So not only was I clueless in terms of collaboration, I had never even had the experience of being a patient in this situation. So I was really just completely flying blind in the early stages, to some degree still am. So I would need to get in touch with certain people to just understand the flow of their surgery clinic, how a patient ends up in that clinic, what kind of happens to them throughout the process, what kind of appointments they have, timelines, that sort of thing. And that information was often hard to get, in part, I think, and another little point of advice here, because the people who are on the ground there, this is all second nature to them. So it often would not occur to them to explain certain things to me, or they wouldn't even really understand what I was asking, because to them it seems very obvious, let's say, how a patient ends up in the general surgery clinic in the first place. I had no idea of that. Now I have a better sense of it. So that period of 6 months or so was a lot of learning how in the world everything worked, trying to figure out the right people to talk to, and then finalizing the materials. Just to add another layer of cluelessness to the whole process, also our IRB, who I'm very close with the people at the IRB because my other line of work is doing a lot of deceptive research, so I've had to get to know them pretty well. So now I'm the problem child at the IRB. So beside all of that, they had never really dealt with, I think maybe really just not dealt with, any kind of collaboration like this off campus, because we don't have a medical school. There just aren't those sorts of projects. So they were also kind of flying blind at first, and so that process took, I guess it looks like 4 months or something, 3 months on their end, which is not that bad, but it did have to go through several rounds of full review. They had to pull in someone from UC Irvine, where they do have a medical school, to consult on the process. Certainly had tons and tons of questions for me, many of which I didn't know the answers to. So that process took a few months, and during this time I was also recruiting research assistants. To interject another little point of advice or warning maybe from the trenches, I found that many times throughout this process I kind of ran into chicken-egg problems. So for example, in order to convey the feasibility of the project to both the campus IRB and the IRB at the hospital, I maybe incorrectly, but I think correctly assumed that I would need to recruit a team to demonstrate, yes, I have these people ready to go, we can start any day that you approve it. And so I recruited some number, I don't know, a dozen or so, bright-eyed research assistants who then proceeded to wait, if you scan down the timeline, until November to actually go in and collect data. Amazingly, none of them, well, some of them graduated, but they all stuck around. So we have actually managed to maintain that team up until this point, adding some people along the way. But that was a bit of an issue where I thought, okay, we'll start any day now based on some assurances I'd been given by the hospital. And then the poor RAs just waited and waited until we actually got started in November. So in any case, that was part of that process as well. Another bit of a hiccup was that this very well-meaning surgeon who we've been working with all along, he had all along been assuring me that once we got approval through UCR, the campus IRB, that there would be this very expedited process, essentially a hand wave, check off a box on a form sort of process with their IRB because, respect for academic institutions, et cetera, et cetera. Unfortunately, when we actually started working with the hospital IRB, their IRB staff had very different opinions about this issue and, in fact, wanted vastly different kinds of information and documentation than I've ever had to provide, even in the most detailed campus IRB review. Essentially, what they were expecting to see from me was a full NIH-style grant proposal explaining all of my analysis and all of my every plan you could possibly imagine, everything you'd have to tell a granting agency, because the kind of research they've only ever had at that hospital was clinical drug trials, that kind of thing, where they would be impossible without grant money. So those sorts of researchers could just hand them their grant proposal. I didn't have such a grant proposal. I had a short couple-page proposal that I put together for a fellowship that I did get, thankfully, so I had some money to get equipment and that kind of thing. But in any case, so that IRB process was treacherous for a number of reasons, some of which I'll talk about in just a minute. So again, the timeline isn't that bad, I think, maybe especially compared to Irene's mini 5-6 year timeline. But I'll tell you at the time it felt felt long, in part because they had been assuring me all along that this would go quickly, and I had this ready team of research assistants eager to start, and I had money that was going to expire at some point, and so I was in a bit of a hurry to start, and it certainly took longer than expected. So we finally got approval around October, and on November 8th, I think you're fine, John. On November 8th, we actually went into the clinic for the first time. And I say we loosely, actually, because I think one of the benefits of this long-ish timeline and the fact that the hospital staff were challenging me at every step of the way, I really had to have my act together by the time we actually started collecting data. So that meant by November 8th, we had a team of, I think, I don't know, it was maybe roughly 12 research assistants. I had hired 2 fantastic undergraduate project managers, one of whom I think is actually on the line right now, who have been invaluable. I couldn't do it without them. So I had them ready to go. We had a schedule ready. I had photos of my RAs with a whole sheet with the languages they spoke. We had everything ready to go. So when data collection started, certainly there were some bumps in the road, but I think it's been actually somewhat smooth sailing since then. And so basically from the initial contact to data collection, it was under 2 years. Certainly could be worse. So in terms of advice, I've certainly given some already, but just a little bit of other advice that's come up in my process here. I'm sort of jokingly saying don't try to do this before tenure. I broke that rule. John is going to say he also broke that rule in just a few minutes. But my point is really more about the fact that if you are going to be counting on those data to get tenure, that's what I'd say don't do. It's impossible to know how long it will take. And whether it'll even happen, there were many, countless times through that 19 months when I felt like, okay, this is it. We're not doing this anymore. I'm going to have to call this off tomorrow because so-and-so is standing in the way and this isn't going to work. And so had I been thinking, oh, I don't need any other data, I'll just publish a bunch of stuff from the study to get tenure, I wouldn't be getting tenure in a few years, certainly. So I think that's really my point there, is that everything moves slowly and often unpredictably slowly. Things you think might be easy are not. And luckily, certain things that might seem hard are not. But on average, I think things take longer than expected. I think Irene really spoke to this point a little bit already, but the one thing I kind of knew from the beginning, thankfully, was that I would need to make clear, if I wanted to make this collaboration work, that my collaborators, loosely defined in this case, but the hospital, I guess my kind of sponsor, maybe you might call them, would benefit in some way from the project. And it's sort of interesting in their case, they're particularly concerned, and they've made this clear to me, about some of the changes that will likely happen in our health insurance and healthcare system in a year or two. I think 2014 is kind of their date that they're focusing on. This particular hospital is a regional medical center, a county hospital, and so many of their patients come there because they have no other choice. And I gather that some of the changes in the healthcare system that are going to roll out in the next few years will provide more choice for some of those people. And so now that that's coming up, they're really concerned about the fact that if they're not giving good quality care and their patients aren't satisfied, they may go elsewhere. So I've had to really reemphasize over and over again. In fact, I almost don't talk about some of the stuff that I'm actually going to be looking at in these data because they don't really care. They just want to know, are you going to be able to tell us how we're doing in our surgery clinic? And I will, so I can tell them that. I've already alluded to some issues with the IRB. I think Irene covered this pretty well. Like I said, I had sort of an unusual experience in that I made eloquent arguments to their IRB chair about the fact that knowing how I was going to analyze the data had absolutely nothing to do with ethical review, and they were not interested in my eloquent arguments. So eventually I just had to give in and say, fine, whatever, okay, I'll do whatever you need me to do to get this going. So I think that may be a more cynical way of putting what Irene put, but ultimately, if you want to have this collaboration, you are kind of at their mercy a bit, and even if they're asking for things that may seem a bit unreasonable, know your limits and know what reasonable boundaries are for your time and your interest. But to a point, at least, you kind of need to do what they say. I think, again, Irene spoke to this as well, though I'll put a different spin on it slightly. Certainly you need to figure out the right people to talk to. She talked a bit about people who are already interested in research, maybe interested in your research questions. In my case, those people don't exist at this hospital particularly, and so I just really wanted to find some people who were well-connected, informed, committed, and pleasant. I think Irene already really covered this. You need to learn their lingo, and they're not going to learn yours and certainly not use yours, whatever yours is, maybe with like my training and very basic research. They don't really care how I talk about things. I need to really learn how they talk, and that's the only way it's going to really work. And then I think probably maybe the most important point from my perspective is that at least in the kind of treacherous collaboration I've had, expect the unexpected. I don't think that's a ridiculous statement, and of course it can't be done, but at this point I've learned to maybe laugh about the unexpected. That may be a better piece of advice. So it's been happening all along the way. It has often taken me literally months to get someone on the phone or an email, someone who is, by the way, charged with working with me, nonetheless will not answer a call or an email for months at a time. And then I'll find out that they scheduled, the orientation weeks before and didn't tell me, so they were surprised when I didn't show up. It's been a lot of really odd stuff like that. A couple weeks ago, one of my project managers emailed me from the clinic in the morning when they were there saying, so it turns out the whole hospital's on strike today. I guess we don't need to be here. And they'd known this for months and hadn't told us. So you really just never know what's going to happen. I could give myriad examples of that, but I think the point is clear. It's an adventure, and I will end on a positive note and say, well, first of all, we have 100 participants now since November, so that's one really positive note. It has, yeah, yay, huge yay. I mean, it has worked. It's not. It's been very draining and I think stressful, but at the end of the day, we have data, and we're about to start looking at the sort of initial wave of data. And I will be starting to submit grant proposals now that we have what essentially can function as pilot data. So, give me a couple of years to shake off some of the frustrations, and I think I'll be speaking very positively about this experience. And also, even with the frustrations, maybe for those of you out there listening who are grad students or maybe very young faculty or postdocs, I was clueless. It's been hard, but I've grown more than I can possibly imagine, like as a person even, having to deal with maybe difficult people or frustrating and confusing situations. I feel like I'm a lot stronger for it. But also, I've just really had to learn a lot really quickly, and I think, we're all academics. We all can agree that it's a very positive experience. So there have been a lot of good things, definitely some struggles as well.
Cool. Well, thank you, Kate. I'll quickly go through my presentation. Mine's gonna be pretty quick, just so we can leave some room for discussion at the end. I will say off the bat that first of all, playing sort of cleanup hitter in terms of the three three presenters here. I will say that I think I sort of view the collaborations that I've had as being fairly successful. They have been time-consuming. I think on the screen here, you can see that I've had two main collaborations. One has been with Akron City Hospital on a framing-based intervention for promoting mammography screening. I've also worked on a test or pilot project of a text messaging-based intervention for promoting diabetes adherence among kids. Each of those projects, I mean, you're looking at least a year, and I consider these to actually be pretty fast, pretty successful collaborations. Part of the reason I think my collaborations have been successful is luckily I've been in an institution where there's been a lot of researchers within my psychology department who have already sort of paved the way with collaborations with some of these hospitals. So the hospitals themselves I've been working with have been pretty sort of open to the process and sort of have had good working relationships. So I consider myself that's sort of one of the things that has made some of my collaboration smooth. But regardless of that, what I have done is talk to a number of the people in my department who have actually had a lot more experience with collaborating with medical institutions about some of the advice that they would have. And so I sort of summarized their advice here on my slide called Advice from the Pros. Again, this is other people's perspectives, not mine, so I don't consider myself in the yet in the company of the pros. But in terms of advice that these people had in terms of identifying good collaborators, I think that's one of the key aspects that will pay off later on in a collaboration. I think one of the things, I mean, I think there might be some sort of idea that if you want to start a collaboration with some kind of medical institution, you just kind of start cold calling people, you know, looking through the medical directory, seeing who's got doing some research closely aligned with what you're doing, and just calling them up and persuading them to collaborate with you. That might work if you're lucky. I think a more successful approach is to get in touch with people you might already know because they're collaborating with people that you already know, or seeking referrals. And that's sort of what I think has been made my collaborations pretty successful in the sense that I was working with people who were referred to me from other people that had collaborations with the hospital. And also in my collaboration with Akron Children's Hospital, I benefited from a quite personal relationship with the collaborators. That collaborator was actually my wife. So that made things a little bit easy. But in terms of also identifying collaborators, it's good. I think if you guys heard Jerry Soul's talk at the SPH pre-conference, he mentioned one of the things in terms of looking for good collaborators is to look for somebody who has some research involvement already, maybe somebody who's been on a publication already. I think that can be a good tip in terms of identifying somebody who's got some experience with the process already. One of the pieces of advice that somebody else told me is also to avoid somebody who's got too much research involvement, meaning that they might be spread too thin with other projects. I think it's pretty common, at least in hospitals, when research projects go on. I think it's been alluded to already by Irene and Kate, that a lot of the research projects people might be familiar with and involved with are clinical trials. And so I think sort of hospitals are sort of catered towards, that's kind of like a standard research protocol that they might be going through. I guess to the extent that somebody might be overburdened with clinical trials that they might be more invested with, having somebody with too much research involvement could maybe be a potential red flag. But I think there might be a happy medium between people that have just a little experience and people that have a lot of experience to find sort of find that sweet spot. The key also piece of advice is to find somebody who's got the ability to motivate research staff. So you basically be looking for a doctor that has authority over the nurses, you know, counter staff, help, because basically it's those nurses and those research medical staff that are actually going to be doing probably a bulk of the work in terms of on the medical side. They'll be the ones probably providing referrals, recruiting participants. So you definitely need somebody who's got authority over them, and so having the ability and control to sort of motivate and get research staff involved is something that would be really important for a good collaborator. Once you've found a good collaborator, how can you set the stage for productivity? I think Irene and Kate have already alluded to, you want to sort of speak the language of the docs. You want to tie your project to outcomes that matter to the doctors. One of the people I spoke to gave the example of if you're researching PTSD, for example. Most doctors might not be interested in PTSD, at least medical doctors, but if you can convince them that, look, you know, people who have PTSD have lower rates of showing up for appointments, lower rates of adherence, if you can tie some of the processes you're interested in into outcomes that are going to matter for a physician, that's one way to get them on board. So I think that's really, really important, is being able to tie it to something that's going to be important for them. A second piece of advice is try and ascertain how research savvy the collaborators and the staff are. And this is where I think there's a huge range in terms of how research savvy medical institutions and collaborators can be. I think everybody, at least I've been with, have been excited to be on board with the project. But in some ways, the biggest piece of advice that I can provide is you kind of have to go back to basics and know that you're the person in charge of the methods and sort of implementing the design of a study. I mean, even some of the most simple things that, you and I, everybody here takes for granted, like, for example, just random assignment, can actually be challenging and in some ways not sort of valued in a medical environment, especially if you're in the position of, like, for example, one of my projects was pilot testing an intervention for text messaging. And it was something where there's one group of kids that were going to get the intervention, other groups of kids that were going to be a control group. And it was actually quite a challenge to be able to get the staff on board with the idea that some of the people are not going to be getting this intervention. I think it was sort of, that idea was a little bit sort of anathema to their perspective, which is that, we're here to help people. You potentially have an intervention that's going to work. Let's get everybody on board with this, and especially let's get the people that are most in need of an intervention to do the intervention. Well, that kind of goes against random assignment, and so that was one of the biggest challenges in terms of explaining that, to pilot test this project and make sure that we have a good intervention, we need to make sure that random assignment is clear, make sure that it's being implemented correctly, and you kind of have to, like, sort of sell people, at least in my experience, on the importance of a strongly conducted research design over the values of trying to treat that person's immediate patients. I think if you can sort of explain things in a way that, if you give everybody, all of your patients this intervention, you might be able to help 50 people. But if we pilot test this intervention and it works and we publish this, that has potential for helping, lots more people, because more people are going to take up this kind of intervention. So I think it's that kind of advice has been sort of helpful, and it's also something that's been suggested to me by some other folks as well. Another advice is start with a pilot project. Definitely, I mean, if you have a huge project you want to get underway, especially with a lot riding on it, like tenure, for example, it's good to start off with a pilot project to see how you work, how the clinic works before you invest a lot of resources into it. And assuming you have a collaboration that works, how do you keep things productive? I think Irene touched base on this. Definitely keep people aware, keep them involved, have regular meetings, keep people up to speed on what's going on, how recruitment's going. And one of the last pieces of advice is, and I think this also ties into what's been mentioned already, is make sure there's, one of the people I talked to phrased it specifically as, make sure there's presence for everybody. For medical collaborators, like MD-level collaborators, maybe what they want out of a collaboration is publication. I mean, if that's really what they value and their institution values, make sure that they're going to be on publication. If they need extra staff time, like funding for staff time, that could be an important thing, but make sure that you know what's going to be important for the collaborator. And also, in terms of research staff, make sure that they are going to get something that's going to be valuable for them. It could be some of their time bought out to help with the project. Of course, then you have to get funding to get that. That's another issue altogether. You can even give out gifts to them with study names, so they get some goodies, and it's got the name of the project on it. Baked goods always help. Nobody's going to turn somebody down if you comes with a cookie. But those kind of things, I think, can help the collaboration go more smoothly. So I know that's the extent of my presentation here. I think now's a good time to open it up generally for questions and discussion. And so what I'm going to do at this point is I'm going to make my best attempt to unmute everybody here. And now we have a little bit of feedback. I'm not sure who the feedback is coming from. But, okay. I'm going to now mute everybody, and if you have questions, please unmute yourself. But we do have some next timer, so please, shoot. I think, Zena, you looks like you have your hand raised, so I've unmuted you.
Hi, thank you. This is great. You guys hear me?
Yep. Yes.
Okay, I was just wondering to what extent people who've had experience collaborating, to what extent you've come in with like set ideas and versus being molded by the institution that you're collaborating with. You know, how much of what your original idea perhaps has been changed by the collaboration?
Mm-hmm.
Or do you come in and just stick with the original methodology?
So this is, oh, go ahead, Kate.
Well, I can just say I'm probably going to anchor the low end of coming in with ideas, but maybe, Irene, I don't know exactly how you started. And so I can just say I didn't, because of the way that mine came together. I basically started with what can I do here? What's feasible in terms of what kinds of patients I can recruit? You know, can I kind of follow them longitudinally? What's really realistic based on the way the clinic runs? And then molded my research questions to that. And then further had to narrow them when I realized the extent of language and literacy barriers I was facing and time barriers within the clinic. So mine very much, I stuck with important questions to me, broadly defined, but really had to mold myself to their institution.
Yeah, so this is Irene. So I actually came in being totally open to pretty much anything that would interest me. I just wanted to get my feet wet in healthcare research. And I mean, I was specifically interested in the healthcare process. What was fascinating is that through our discussions, my colleagues found what I'm an expert at as more interesting than anything I could contribute to what they're an expert at. So we actually ended up, you know, with the project, we actually have several projects that are exactly what I love doing, and but that was because I couldn't even tell you who convinced whom, but they thought, yeah, we want to do what you want to do.
Yeah, I would say in terms of my collaborations, they've been mostly kind of going ahead with some of the ideas that I had, so largely sort of unaffected by kind of any issues that the collaborators had wanted, although with some exceptions, definitely when I was putting together study ideas, discussing things with some of the doctors and other collaborators, definitely opened my eyes to some other outcomes or some other issues that I wouldn't have ordinarily been. So definitely there was a little bit of give and take, but I would probably say in my collaborations it's been more along the lines of keeping my own control of the projects.
Yeah, and I would also point out that, you know, as social psychologists, one of the things we're really great at is process. And so I was interested in studying the processes, and I didn't really care about what domain we did it in, so choosing hypertension, choosing blood pressure control, looking at medication adherence, that was all my colleagues, but I was totally thrilled to do that. I just wanted to study the processes that I was interested in.
Okay, great. I believe, Rachel, you had your hand up for a question.
Yes, I was just wondering if you could speak a little bit about how the publishing and data analysis process operates a little bit differently. I currently work at a medical college, and I'm the only psychologist on campus. And actually, now that I've been here a couple of years, people are starting to realize what I do and offering to have me consult on projects and things. So I'm just curious if you could speak to that a little bit.
So I think I was the one who raised that. The publication process, for me, what's different is mostly where you publish. So my colleagues are not the least bit interested in publishing in a social psychology outlet. And given that I have tenure, I'm fine with that too. So it works for us because they want to publish for clinicians. They want to talk to clinicians. This is important for clinical care. And so, you know, and I'm happy with that. That's the kind of impact that I'm happy with at this point in my career. But I could imagine that being very frustrating if I were at a different point and I really wanted to publish in JPSP and JESP and PSPB, and they would not like that. The other thing I would say that is different is just in terms of the process. I mean, part of it's driven by the medical journals. They're very short. You don't have much room to give theory. I thought I was giving my colleagues a really stripped-down version of an intro, and they just laughed at me because it was over one page. So there's that. And they're also, they thought it was surprising I kept asking for feedback on drafts. I'm used to going, you know, I don't know, 4, 5, 12 rounds on papers with colleagues. And in this environment, they pretty much thought I should see it that we should show it to each other maybe twice.
You're lucky, actually. In some of my collaborations, I think they looked at it lucky if it was once.
Yeah. And then the data analysis part, that's all driven by the fact that it's totally out of my hands. I don't touch the data, and that is just weird. John, do you analyze your data?
Yes. That's why I'm actually flabbergasted that was out of control. I think that's one of the aspects that I like the most out of projects. And so, yeah, I've done all the data analysis myself. I think it's with my collaborations. I think I've never had the collaborators involved with the data analysis, largely because I'm not sure if they have the experience to do it. But
yeah,
I'm sure every arrangement is different.
There was no question. None of them have statistical expertise, my collaborators, and so. And I knew once to the medical data, I would very quickly lose expertise. So we had to have biostatisticians. Once biostatisticians, then they do everything. And first I thought that was going great. When we wrote it down, that seemed like, oh, wonderful, I have to do that. But it actually turns out to be very frustrating.
Yeah, I can imagine. Any other questions that people have? The floor is open. We have a question from Elizabeth. It says, in your experience, have any medical professionals ever reacted negatively to the idea that biases might contribute to poor health outcomes for their minority patients?
Reacted negatively. You know, we actually had really good responses from the providers. I'm sure there were some who reacted negatively internally. Didn't have a lot of open hostility, though. You know, I would find so our recruitment process was me and a physician advocate from each institution. We would go to every single clinic and give presentations and talk to people, and of course bring them lunch. And it had to be a good lunch, I was told. It couldn't be pizza or bagels. It had to be like catered nice sandwiches and, you know, whatever. So we had to work all that out. And we'd walk in there and we'd kind of give the topic of it, and you just get these blank stares looking at us. But once I got into what we called the toys, which was perceptual illusions in our case, once I could show them something and that it was like, okay, this is like real science, it's not, you know, psychodynamic Freudian processes, which I don't know, that might be what they're anticipating. Then they were all over it. Then it was all, everyone would open up and talk and chat, and you know, they definitely put me through my paces in terms of, are you really going to be able to say anything about bias, or are you going to unfairly attribute disparities to us as bias, which has been done in the literature. So we had to talk a lot about all the different controls that we were going to use methodologically, statistically. Yeah, you know, there were people who the conversation would kind of devolve into sometimes frightening discussions of, well, it's those people's fault, essentially, was what we would hear. You know, we would kind of just like try to guide it onto neutral ground. But yeah, I never got really bad reactions.
Oh, that's good. Okay, any other questions? I think we're a little bit over 2 o'clock, so I think I know we have the schedule for an hour. We can talk a little bit longer, but if nobody has any other questions for any of the panelists, I think we can go ahead and wrap up the Brownbag. Thanks to everybody for participating. Thank you to Irene and Kate for presenting on the topic. Thanks to all the attendees for hopefully overcoming any kind of technological difficulties that that this format might present. I just want to make a couple plugs. We have had this Brownbag recorded, and we're going to be exploring some ways to post it online. So that'll be available for some other folks who weren't able to make it. And also, 2 months from now, on April 18th, we'll be having our next SPH Brownbag. It's going to be hosted by, our presenters are going to be Tamara Schneider from Wright State and Angela Bryan from University of Colorado, who will be talking about working with high-risk populations. And so that's going to be on Wednesday, April 18th, at the same time from 1 p.m. to 2 p.m. We'll be sending some announcements out for that through the SPH listserv, through Facebook. And also in the next day or two, for those of you who are attendees, we'll be having a sort of follow-up questionnaire to get you guys' take on how it worked, any ideas you might have for future brown bags or things that we can do to tweak this format so that it can become more successful. So that is, again, I want to say thanks to Irene and Kate for the time and the presentations.
Thank you, John. And maybe we should also, I don't know if I should offer up Kate, but certainly myself, if there are folks out there who would like to contact me personally by email, I'm happy to talk with you.
Yeah, me too. I was going to say the exact same thing and worry about offering you up, so that worked out perfectly.
I'm able to answer questions too. So great. Well, thanks a lot. I think with that, we will officially conclude the first brown bag, and we'll have more on the docket coming up soon. Thanks a lot.
Thanks, John.
Thanks, John.
No problem.